Hi everyone, we're going to be talking about pulmonary rehab treatment. Talking about aerobic exercise prescription as well as airway clearance techniques and breathing patterns as well of how you would educate a patient. So, excuse me, first things first is to go on page 386. Let's see, I believe it starts on 384 for things that we've just previously discussed from the previous lecture. But we're going to be talking about aerobic exercise prescription and what that looks like. So again, 386 of Score Builder's textbook. So aerobic exercise or cardiorespiratory endurance exercise refers to submaximal, rhythmic, repetitive exercise of large muscle groups during which adenosine triphosphate is synthesized primarily by a long-term energy system and utilization of inspired oxygen. So that's the definition of aerobic exercise prescription. So indications, to reduce cardiorespiratory endurance, because of reduced cardiorespiratory endurance. Indication is because of primary or secondary prevention of cardiovascular disease. So precautions and contraindications would be make sure that you're doing the appropriate screening and performed prior to beginning an exercise training, identifying the known diseases, risk factors for CAD, and other factors will optimize adherence, minimize risk, and maximize benefits. Also avoiding the Valsalva maneuver, making sure the patients and educating them that they're not holding their breath during the procedures. So what we're going to look at too are some different definitions. So you might have heard the term VO2 max before. So we want effective aerobic exercise training improving VO2 max, directly related to intensity, frequency, and duration of aerobic activity. So interacting between these two major principles of exercise training of overload and specificity. So that's what we've already talked before. So overload principle again is improving its function. A tissue or organ must be exposed to stress or load greater than that which is normally encountered. Specificity is that long-term adaptation to the metabolic and physiological systems derived from exercise that are specific to the exercises performed and the muscles involved, and including that with like ADLs of any kind of performing it specifically. So mode, you really definitely want to use large muscle groups when it comes to aerobic exercise prescription. It's rhythmic activities such as, as long as it's performed safely, walking, hiking, running, jogging, bicycling, aerobic dance, rope skipping, rowing. It goes on and on for aerobic exercises. So looking at intensity, so you're going to look at a target heart rate zone for your patient. Established from lower and upper heart rate limits that are calculated depending on age, fitness level, health status, and goals. So looking at the method 1 on here too, so there's two different methods. So there's just a maximal heart rate in which the lower target heart rate, which would be the heart rate max times 55%. So you're going to take 220 minus your age and calculate that by 55%. And then by 90% is going to get your lower and upper target heart rate. Method 2 is performing, the heart rate max, 220 minus your age, minus your heart rate rest, times 40% and times 85% to give you the lower and upper. So again, heart rate max is maximal heart rate measured during a graded exercise test estimated by 220 minus your age. Then the heart rate rest is you're literally going to have to calculate the resting heart rate. So duration of the activity, intensity of the activity. So, it's usually continuous or intermittent activity for 20 to 60 minutes. Minimally of 10-minute bouts are accumulated throughout the day. Lower intensity activity should be performed over a longer period of time, so more than 30 minutes. Higher intensity activity should be performed for 20 minutes or longer. Moderate intensity activity or longer duration is recommended for adults not training for athletic competition due to the potential hazards and adherence problems associated with the high intensity activity. So with all of these, as far as how long and how long you would train them for, you're going to be looking at the ratings of perceived exertion, that table, and that is on page 384. Before it was described as very, very light, somewhat hard. You're going to ask them throughout, how challenging is this activity while they are performing it. So make sure you look over those modes and methods again for RPE. Let's see, frequency for aerobic exercise prescriptions recommended to perform 3 to 5 days per week. As the PTA should be aware of normal cardiorespiratory responses. So making for sure, that you're looking at all of their vital signs before, during, and after, if possible. So normal cardiorespiratory response to acute aerobic exercise would be increased oxygen consumption due to an increased cardiac output, increased blood flow, and oxygen utilization exercise skeletal muscles. There will be a linear increase in systolic blood pressure with working load, so up to 8 to 12 millimeters of mercury per minute. So we're going to look at METs too. No change or moderate decrease in diastolic blood pressure, so no more than 10 to 15 millimeters of mercury is considered normal. Increased respiratory rate and tidal volume. Chronic adaptations to aerobic exercise, so is increased at maximal exercise would be VO2 max. Heart rate, no change or decrease at maximal exercise, decreases submaximal exercise. So you can look through each one of these in the definitions and what would be considered chronic adaptations to aerobic exercise. So make sure again you look over that. We're going to be talking about some different, with your vital sign assignment, and there are some different scenarios, some different case studies, and aerobic exercise prescription for that too. Let's see here. So for pulmonary treatment, now we're going to be talking about more about airway clearance techniques and breathing techniques. This should be administered prior to eating or at least 1 hour after meals. So making for sure that you percuss and vibrate over each segment to be treated for at least 3 to 5 minutes. After each segment has been treated, there should be a cough performed afterwards. You want to allow a rest period after each segment is treated. Review breathing exercises in each drainage position. Treatment should not be done more than 45 to 60 minutes secondary to fatigue. So if you look in your faculty skill checkoff, I want you to read over each one of these of what we will be doing, especially for the percussions and also for breathing techniques. So active cycle breathing, diaphragmatic breathing, and pursed lip breathing is described in the score builders, but also on PhysioU as well. So who needs this pulmonary treatment? So those that have acute or chronic respiratory problems, inability to expel pulmonary secretions, have ineffective cough, have increased secretions, pneumonia, neuro impairment that cause swallowing difficulties. So, depending on your facility and where you're working, usually this is more an acute care setting or rehab setting, but I'm sure the treatments have increased exponentially because of COVID. So I'm sure a lot of patients have needed this treatment as well. What good does pulmonary treatments do? So it mobilizes secretions to move it from one place to another in the lungs. Expel secretions is what we want out of the lungs. To improve breathing patterns, improve ventilation through all lobes, and improve overall function. So, okay. So abnormal breathing patterns, which I've described briefly but previously in the other lecture. If you go to page 385 in Score Builders, it speaks about common breathing patterns. So even apnea is absence of spontaneous breathing. BOTS is irregular breathing. Bradypnea is slower than normal respiratory rate of less than 12 breaths per minute. A lot of times might be associated with neurological or electrolyte disturbance, infection, or high level of cardiorespiratory fitness. Cheyne-Stokes is decreased rate and depth of breathing with periods of apnea can occur due to central nervous system damage. Eupnea is normal rate and depth of breathing. Hyperpnea is increased rate and depth of breathing. Hypopnea is decreased rate and depth of breathing. And then tachypnea is faster than normal respiratory rate of more than 20 breaths per minute in adults. So, and then there's also hyperventilation, which is deep rapid inspiration as well. So make sure you know each one of those. And the term dyspnea means distressed breathing secondary to shortness of breath. So the other ones too would be orthopnea. So it's difficulty for them to breathe. Supine, so relieved with sitting upright or standing. Apnoresis is cessation of breathing in the inspiratory phase. So, the Cheyenne-Stokes is increase in tidal volume followed by decrease in tidal volume. So breathing or shallow stops, then it starts again, and then gradually shallows. Sometimes this is associated with head injuries. Other thing too, for those that lack an abdominal strengthening, especially if those spinal cord injury patients or traumatic brain injury patients, resting position of diaphragm is lower, resulting in decreased inspiration. Abdominal binders can help provide support to abdominal viscera to assist with ventilation. So do not constrict the thorax with abdominal binders though. So if you're not for sure what that looks like, you can look that up on Google or pictures. Coughing should be sharp and deep. Pulmonary dysfunction may be weak, shallow, soft, or and paralysis or pain may be weak or shallow coughing. So coughing is described in Score Builders on page 387 to 388. So as you can see on your skill checkoff for coughing, after you perform the techniques, then you're going to have them inspired to a near maximal inspiration. So then they're going to close the glottis, so like bear down by tightening abdominal. Sometimes I might need a little bit of overpressure by the PTA to help with this. Open glottis to allow inspire of air to forcefully exit. So to improve cough, sit leaning forward with neck flexed, arms supported, and feet firmly planted on the floor. Apply pressure or vibration to the extrathoracic trachea to elicit a cough reflex. Apply pressure to the mid-rectus abdominis area after inspiration. Apply pressure along the lower coastal borders during exhalation. So all these are going to be people that are having a difficult time producing a cough. Huffing is a little bit different. Huffing is instruct the patient to take a single large inspiration followed by a short expiratory effort with pauses in between. So coughing, is coughing, but huffing's like so forced huffing. So as you look on page 387, so for airway clearance techniques, kind of already talked a little bit about each one of these, but indications, make sure you look for that too. To obtain sputum for diagnostic analysis could be another indication for airway clearance. Let's see here. Active cycle of breathing is the first one. And this is a breathing technique you would have to do with your patient or during the faculty skill check-off. That's the first one described. So this is what I'm going to have you look for during lab. So a technique was developed under the name of forced expiratory technique, assists with secretion clearance in patients with asthma. The name of the technique was changed to active cycle of breathing to emphasize that ACB always couples breathing exercise with the huff cough. Includes 3 phases: breathing control, thoracic expansion exercises, and forced expiratory technique. So the procedure, and I'm pretty sure there's videos from PhysioU to look at active cycle of breathing, almost positive. So gentle relaxing breathing, maybe diaphragmatic breathing, at patient's tidal volume or resting respiratory rate for 5 to 10 seconds or as long as the patient needs in order to prepare for the next phase. Thoracic expansion exercise, 3 to 4 deep, slow, relaxed inhalations to inspiratory reserve with passive exhalation. So where they're just breathing in 3 to 4 deep with relaxed inhalations to inspiratory reserve with passive exhalation. Chest percussion, vibration or shaking may be combined with exhalation. So while they're breathing out, you do a vibration technique or percussion or shaking. Forced expiratory technique is 1 or 2 huffs at mid to low lung volume with the glottis open into the expiratory reserve volume. So brisk adduction of the upper arms may be added to help compress the thorax. So adduction of the upper arms for compression. So precautions and contraindications would be splinting postoperative incisions to achieve adequate expiratory force. Bronchospasm or hyperactive airways would also be a precaution or contraindication. All right, so looking at the next term on 387 is going to be autogenic drainage. So is used to control breathing to mobilize secretions by varying expiratory airflow without using postural drainage positions or coughing. So this is to improve airflow in small airways to facilitate movement of mucus. So this requires patience to learn. So this may not be subtle for young children and patients who are not motivated very easily, or they're easily distracted. So this does not require the assistance of another person or equipment. It can be performed anywhere and during activities of daily living. So the patient sits upright in a chair with back supported, controlled breathing at 3 lung volumes. So unsticking phase is slowly breathe in through the nose at low lung volumes, followed by 2 or 3 second breath holds to allow collateral ventilation to get air behind the secretions. Then exhales down into the expiratory reserve volume. Collecting phase is breathing at tidal volume, interspersed by 2 to 3 seconds of breath holds. Evacuating phase is deeper inspirations from low to mid inspiratory reserve volume. So you can, and so in this treatment, exhalation through pursed lips may be used to control expiratory flow rate. This is about 30 to 45 minutes, requires motivation and concentration to learn this technique. So the next thing, talking to is productive versus non-productive. Non-productive have, you want to make for sure that you're going to have secretions from this too. The color could be clear, yellow, green, or blood stained. And the consistency of what it looks like too. The amount or minimal, or is it copious? Odor or no odor, is it foul? So for a directed cough and huffing, a directed cough tries to compensate for the patient's physical limitation and elicit a maximal forced exhalation. Huffing is a forced expiratory maneuver performed with the glottis open, and this maneuver is, kind of like if you were fogging a pair of glasses, like although a huff does not produce the same airflow velocity as a cough, potential for airway collapse is less. So huffing may be reinforced by a quick adduction of the arms to self-compress the chest wall. So read through the rest of the procedures for coughing, kind of describe that, and the huff as well, and what the precautions and contraindications would be. Then talking about postural drainage, percussion, and vibration here soon. So I'm going to move on. So if it's copious and clear, could be chronic, could be bronchitis. If it's yellow, green, purulent, or foul odor, it might be a type of infection. If there's bleeding, then there might be hemoptysis, hemorrhage within the lungs. If it's frothy or white, could be pulmonary edema or heart failure. So precautions: never allow the client to suck air in by gasping because it increases the work of breathing and patient fatigues more easily, may lead to bronchospasm, may push mucus or foreign objects into the air passages. So manual pressure on the abdominal area. Pressure could be applied by the PTA or by the patient themselves to increase intra-abdominal pressure to cough forcefully. Avoid direct pressure on the xiphoid process. So, this is how you would perform and put your hand placement in interlocking. Instruct the patient to breathe as deeply as possible. PTA instructs patient to cough. When patient coughs, the PTA provides an inward and upward force. Patient should cough twice. So if it's self-assisted, then they're going to have their arms crossed over abdomen, hands interlocked below the xiphoid process. After deep inspiration, they push inward and upward and cough twice. So all of these could be, make sure you study on page 391 to 394. Let's see here. Diaphragmatic breathing, make sure you understand what that means too, precautions and contraindications. We're going to go through that more so during lab as well. There's paced breathing and exhale effort, pursed lip breathing. There's segmental breathing. And these are going to be the positions to relieve the dyspnea. So on page 394, make sure you know the difference between reverse Trendelenburg position and semi-Fowler's position as well. So these are usually the typical type of patients you're going to be doing breathing exercises with. These are going to be the goals for breathing exercises, so you can read over each one of those. So, guidelines is educating them, make sure that they're in the correct position, demonstrate desired breathing pattern, have a patient practice correct pattern in different positions. So again, these are all precautions I've previously discussed, but make sure you look over these too. So diaphragmatic breathing, and this is described also on page 391 in score builders of indications and precautions. So positions in semi-Fowler's position, place hand over rectus abdominis muscle, place other hand over sternum, instruct the patient to inspire slowly and feel the abdominal hand rise, so that way you can initiate the diaphragm instead of using accessory muscles for breathing. So designed to teach patients to use diaphragm and relaxing accessory muscles, as I just described. So it increases efficiency of ventilation, increases excursion of a chest, increases gas exchange, decreases the amount of work that's required for breathing, and mobilizes lung secretions during postural drainage. Pursed lip breathing is instructed patient to avoid using, abdominals, patient places, or to, use abdominals. Patient places hand over abdominal while breathing, slowly inhale, relax and loosely pursed lip during exhalation. Expiration should be twice as long as inspiration. Thought to keep the airways open, used to help COPD patients deal with episodes of shortness of breath or dyspnea. Avoid forced expiration. So make sure you look over the segmental breathing and what that looks like and how it's described. We've already looked at a spirometer too, so that would be 7 to 10 times per session, 3 to 4 times per day. You can look up different YouTube videos of what that looks like. So getting into different positioning, percussion, and drainage. So positioning Trendelenburg means the head is down in supine and inclined to 45 degrees, and drainage of lower lobes can increase blood pressure if patient is hypotensive, intolerant for patients with CHF, pulmonary edema, hypertension, or shortness of breath. Reverse Trendelenburg is supine when the head is above the trunk, inclined 45 degrees, can decrease blood pressure if patient is hypertensive, allows diaphragm to be lower as compared to supine. Semi-Fowler's is head of bed elevated to 45 degrees, pillows under knees, drainage of lower lobes. So make sure you know each one of these in the chart here, too, in the different positions, and they describe what lobes are being utilized. And look in your skill check off. The previous slide, the picture is from O'Sullivan, page 459, and we're going to be talking about this information from O'Sullivan. So, postural drainage and the means of mobilizing secretion in lung segments to centralize airways. It utilizes gravity assist with drainage. Cleared by cough once in larger airways. Treatment should not exceed 60 minutes. You want to check vital signs and breaths. Maintain each position for 5 to 10 minutes. But breathe deeply but relax so you want to avoid hyperventilation. Make sure you look at 12.4, box 12.4, that lists precautions to be considered as well for drainage. They're not absolute contraindications, but relative precautions. And there's a range of considerations should be addressed before initiating any kind of postural drainage. So here are some different contraindications. Make sure you know all these contraindications. So for percussion. So percussion is a forced rhythmic applied by the therapist with cupped hands. It's applied to where specific areas of the thorax and how it corresponds for each lung segment. Technique is usually 3 to 5 minutes over each involved lung segment. Percussion is thought to release the pulmonary secretions from the wall of the airways into the lumen of the airway. So when coupling percussion with the appropriate postural drainage position for the lung segments, its probability of secretion removal is enhanced. Percussion is a forced directed to the thorax, there are conditions that would necessitate caution with this technique, such as fractured rib, a flail chest, osteoporosis, elevated coagulation studies, or a decreased platelet count. So those would all be considered contraindications and precautions as well. Okay. So kind of just, some other thing too is if they have spinal fusion, over tumor area, pulmonary embolism, condition which hemorrhage easily, like a low platelet count, anticoagulation therapy, if they have unstable angina. So with vibration, that's when you use both hands on top of the other. I'll show you this technique. Can be used with percussion and postural drainage applied only during expiration over chest wall. Pressure applied in the same direction as chest is moving. Shaking is the most vigorous form of vibration during exhalation. Uses intermittent bouncing. So following a deep inhalation, a bouncing maneuver is applied with a therapist's open hand to the ribcage throughout the expiratory phase of breathing. Shaking is applied to a specific area of the thorax that corresponds to the underlying involved lung segment. 5 to 7 deep breaths with shaking or exhalation are appropriate to hasten the removal of secretions. Shaking is commonly used following percussion in the appropriate postural drainage position. This consists of a force applied to the thorax. The same circulatory and musculoskeletal considerations are needed for application of percussion. So, as well, there is airway clearance and precautions in postural drainage, box 12.4. Precautions for the use of Trendelenburg position, make sure you look for that. Precautions for the use of side-lying position too. Kind of going back to what I previously already discussed as far as aerobic exercise, what you could do. So I've already mentioned these already at the beginning of this lecture, but make for sure you look at Score Builders page 386, and then let's see, exercise prescription on page 451, it looks like, and O'Sullivan page 456 to 457. That would be all O'Sullivan. So make sure you, again, look at what a VO2 max is, and there's a video for that, and how measure of maximal oxygen your body can utilize during exercise. It's also known as peak oxygen uptake. So look over that video on Blackboard. So there's different exercises and information that's described in your O'Sullivan textbook. That's a little bit different and more detailed than on the Score Builders. So obviously checking vitals before, during, and after for any of the exercises that you're performing. For any of the exercises, there should always be a warm-up component that is timed to slowly increase heart rate and blood pressure to ready the cardiovascular, pulmonary, and musculoskeletal system. Again, making for sure that, if they're performing stretching exercises, should be to help prevent injury, but make sure that they're not performing the Valsalva maneuver. So with strength training, while cardiopulmonary endurance training is continuous or discontinuous exercise for pulmonary rehab, generally strength training has been found to counter the systemic effects of COPD and result in peripheral and ventilatory muscle weakness. The strengthening of both upper and lower extremities has shown to increase with appropriate training. Weight training of the targeted muscle group has been described in a variety of ways. So 8 to 15 or 8 to 12 reps before fatigue for strengthening. Okay, for all of these, making for sure that they're breathing appropriately and not performing the Valsalva maneuver. Exercise progression, so using RPE and trying to, if they're performing like 20 minutes of continuous activity, and actually asking them for the duration and intensity, the RPE of what they're experiencing at that time. Okay, gonna kind of move on to, so intensity, so looking at VO2 max, heart rate, RPE, and percent of peak workload, 40 to 60% of VO2 max on exercise tolerance test. Heart rate should be a range, most practical way to measure, so looking at their target heart rate, and also RPE and the Borg scale for that. Borg RPE, the 6 to 20 scale, so there's 2 different types, so make sure you look over each one of these. This would be 12 to 13 would be 40 to 60% of VO2 max, 14 to 17, 60 to 90% of VO2 max. All right, let's see here. So duration should be about 20 to 30 minutes for aerobic exercise. Frequency can tolerate 20-30 minutes, 3 to 5 times per week. And if a patient has low functional work capacity, you may have to separate it into 2 times daily. So again, mentioned it in the previous, but make for sure that you review all the respiratory pathologies and review those as well before trying to perform any of these techniques. All right, and that concludes our session today for rehabilitation treatment, and we will talk more so for pulmonary rehab and what that looks like. And make sure you look over your skills checks prior to and the positioning. So the positioning is being described starting on page 390, and again in your also describes in your O'Sullivan textbook. So make sure you look for each of these positions before we initiate them. Oh, sorry, they start on page 389 in score builders. All right, thank you all. Have a wonderful day.